You should do a regular pain assessment even in the absence of pain, because you don't know sometimes, and you'd be surprised that you might pick it up because you think it's behavioural, but in actual fact it's pain. Yeah. They don't always say, I've got pain. Yeah, like there. Yeah. Yes, yeah, that's great. Okay. Yep, so you can do your pain and your behavioural assessment side by side, try and sort out what's going on. That's a great idea. Okay.
There I go again, Ron, turning myself off. I put one or two handouts on each table, or with Jackie's help. Again, this will be in the package of information that's on the website, so it's not really about each of you having your own. But what we're going to do now is, because the work that you do is with an individual resident, and we're talking about resident-centered care. We've been talking kind of in general now, but we want to introduce you to some of the specific resources that we've made reference to, and kind of give you an idea of how you would use these resources. And there's going to be really two groups of resources that we're going to draw on. One is the group of resources that the research team that I worked with developed, and that was the Quality Palliative Care in Long-Term Care Alliance. And so those are the resources that I showed you in that large book and are on our website. There are cards there with the web address on it. And then the other group of resources was developed by Deb and her team in Australia. And they are also on the website, and Ron's going to show you quickly that website just before we see a video from. So you'll be familiar. You can go back to these websites and look up some of these material yourself. So remember me and my phases and my bubbles, you know? So we're kind of going back to the phases and the bubbles of the journey of the resident, but now we're going to try and individualize it to one resident that we're going to call Carolyn. And we're going to walk Carolyn through her journey in long-term care and think about, you know, how would we do advanced care planning at the time around admission and shortly after? How would we do a palliative care case conference so we would know what her wishes are? And then in the second phase, as she's transitioned more to have palliative goals of care, how would we identify and screen for pain and symptoms, similar to what Deb talked to you about? And then thirdly, as Carolyn transitions to end of life, you know, what kind of communication tools and resources can you use in your home to help residents and families and staff? And lastly, the behavior and peer support in the grief and bereavement phase. So first of all, I'll let you meet Carolyn, and I'm going to read you the first part of the case study. You have a copy on your table, but you don't have to look at it. I'm just going to read out what is sort of an introduction to resident Carolyn. So Carolyn Gladys McIntosh is 91 years old. She speaks fluent English, but originally came from Paris, France, where her family was based. Her father was captain of the Canadian Army base in Versailles. At the age of 18, she fell head over heels in love with a handsome Canadian soldier named Stanley McIntosh. They married in Paris after a whirlwind 6-month courtship, and shortly after moved to Canada to begin their new life together. Carolyn and Stanley were happily married for 50 years. Who says there's no such thing as love at first sight? Sadly, Stanley died of a heart attack at the age of 65, which was a traumatic event both for Carolyn and her young son at the time, Alex. This death challenged her faith and religious beliefs, and she now considers herself an atheist. Carolyn worked as an elementary school teacher for many years where she taught home economics. After numerous miscarriages, Carolyn and Stanley were blessed with a beautiful baby boy named Alex. Alex, the son, is now almost 60 years old and drives a transport truck throughout Canada in the United States. He makes a point to visit whenever he is in town and calls when he can, but unfortunately, this is never as often as Carolyn would like. It's not unusual for Alex to go a month or two without seeing his mom. Carolyn considers him her pride and joy and misses him deeply in between visits and phone calls. Carolyn is having difficulty managing at home. She now must move into long-term care home. A bed has become available, and Carolyn moved into the long-term care home where you work approximately 6 weeks ago. It was at that time that she was diagnosed with dementia, but her doctor suspected she'd probably had it for a number of years before. During her admission assessment, Carolyn was very clear that she did not want any extraordinary measures and wanted to allow a natural death. And that's a lovely way to think about it, isn't it? Allow a natural death. As such, she has a DNR order, do not resuscitate or do not attempt resuscitation, which it's more appropriately referred to. She's at risks for a fall, and she's had multiple other chronic health conditions, such as high blood pressure, osteoporosis, arthritis, and glaucoma. How many of you think you have a resident something like Carolyn in your home? Yeah. So you've met Carolyn, and Carolyn is going to be someone that we can sort of reference our conversations about. In the Quality Palliative Care and Long-Term Care Toolkit, we have an advanced care planning module, and we've talked about the importance of advanced care planning, but this particular module explains it and describes it for staff and gives communication tips and a checklist for how you go about doing advanced care planning with families and with residents shortly after admission. I don't know if you have one of these on your table. Do you? No. So you can download them, and I'm just going to walk through some of the tools and explain to you what they are. One of the things that is really important is getting that conversation started. They're hard conversations to have, as Marg and Jackie mentioned. But some of the tips that the staff gave us were words like, tell me about your health and illness. You know, get started, open-ended. What have the doctors told you about your health or illness condition? What do you understand about your health condition, and what does your family understand? What fears or worries do you have about your health, your illness, or your medical care? How has your illness interfered with your quality of life? Tell me about what you understand about the options for treating your illness. So you notice it's very gentle. in the School of Social Work, where I work with Marg for many, many years, one of the ways that I've talked to students about starting difficult conversations is find a way to give people the invitation to talk about it, giving them the invitation. So it's not, we're going to sit down and talk about your end-of-life care wishes now. That's not an invitation. That's like a demand. But an invitation is, tell me about what you understand about your options for treatment. How has your illness interfered with your life? Tell me about your health. Has this changed what you value and believe? Tell me more about that. Inviting, open-ended. What fears do you have now and for the future? What decisions do you feel you may need to make for the future? Have you thought about what your decisions might be? Who have you talked to about your decisions? Have you talked with your family about your decisions and your future medical care? And I'm presenting this as if it's all one conversation, but of course it's not. It might happen in bits and pieces over time, gently giving people the invitation. It might be while you're giving a resident a bath. It might be, while you're doing some kind of personal care. So it's that gentle, open-ended kind of invitation to share their thoughts and feelings. And residents and families almost unanimously told me that they want to be invited to have these conversations, but they are looking to you as the people they consider to be the experienced people, the professional people, to start the conversations. So those are some of the sample advanced care planning questions in the toolkit. There's a checklist for staff so that you can go through and look at what are some of the main issues that you want to have information. Some tips is about communication, as I've described. And then scheduling and planning a meeting where staff can make sure that they're all on the same page about advanced care planning. I'm just going to take a minute to talk a little bit about, I did earlier about the advanced care planning from a kind of a legal perspective. But it's a voluntary process where a capable person reflects on their priorities, values, beliefs, and traditions. Remember, I said it's their wishes. It's not healthcare consent. It's in the future. It's hypothetical. It's their wishes. And if a resident is not deemed to be capable of making a treatment decision, then the information assists the substitute decision maker in that time. So when you call and say, this is the situation, do you want your loved one to go to the hospital? You're in a position to say, no, as a substitute decision maker, I've had that conversation. This is not the wishes. And if the Healthcare Consent Act allows for everybody to have a substitute decision maker in that hierarchy through the family, spouse, child, etc. But ideally, people choose someone that they consider that they trust, that they want to be the one to make their decisions on their behalf and make what's called a power of attorney for personal care. So I have a power of attorney for personal care, and my partner is my power of attorney, and vice versa. But we've talked about what our wishes are. Because the power of attorney for personal care, their job is not to do what they would like to see happen. Their job is to do what they understand that person's wishes would be. Whether they really agree with them or not, or whether it's a tough decision to make. And that's why having that conversation And actually telling as many people as you can, you know, although my partner is my power of attorney, I also want my 2 children to know, so my partner and my children don't get in a dispute about what it is, because my partner actually isn't their father, you know, so families get complicated. And so you want to tell as many people as you possibly can, so that everybody understands that these are your wishes, and you can write them down, even very informally, you can write them down. So always encourage people to talk about their wishes and think about who they most have confidence will represent their wishes through a power of attorney for personal care. So some things to think about, and this speaks again to the impact of Alzheimer's and related dementias, but only capable individuals can express their wishes. All the more important to have these conversations early. But the wishes can be expressed in any way. So although you can write them down, and it's a good idea to write them down, you don't have to write them down. It can be verbal, and they can tell staff, they can tell their family, and wishes are just as official when they're verbal as when they're written. And I said this already, that they inform your substitute decision maker about the healthcare decisions that you want them to make on their behalf. Wishes are not consent, and you have to go back and reconfirm that the decision is still the decision that people want to have. And later wishes trump over previous ones. People change their mind, and that's okay. They can change their mind. All right, so that, getting back to Deb's point about documenting, it's a different point, but it's so important to document every time you have these conversations with people, because people can change their mind. An advanced care plan, even when it's written, I said it's voluntary, so it helps you a lot. And it helps the substitute decision maker a lot, but you can't make somebody do an advanced care plan. And actually, we're learning in some cultures, Paula made reference to my work in First Nations, they don't make advanced care plans, or at least they don't make advanced care plans in the way we think of advanced care plans in the medical system, because it's not considered culturally appropriate. And it's not, as I said, a blanket document, just like competency. Each specific situation has to be revisited, and consent has to be given for a treatment or moving to hospital. And if the resident is capable, the resident makes the choice, but if they're not capable, it's made by the family. And the advanced care plan cannot be made by the family, just the resident. The family carries out the wishes and can make the care plan and consent based on the advanced care plan. So if you've got good advanced care planning done, then you can inform the care planning that Deb is going to spend more time on in the case conference part of it. But then that's that meeting where you share all that information between the resident, the substitute decision maker or power of attorney for personal care, and members of the healthcare team. And a care plan, especially for palliative and end-of-life care, is holistic. So it's the medical, psychological, social, and spiritual needs. And it leads to that plan of care that you follow as a healthcare team. And it's about the present care. So I've talked about all of these conversation starters, and I'm going to move on now, and Deb's going to talk a bit about a palliative care conference, and she's going to show you a video that she... Oh, okay. Yeah, okay. So this is another tool, and I'm going to talk about the palliative performance scale after Deb does her video and show you how to use it. It's a very, very good screening tool to help with identifying when a resident is transitioning, so the goals of care become more palliative and less restorative. But that's what the tool looks like. Most of our tools have the same sort of visual identity, and they kind of walk you through all of the different processes that you need and tell you how to use them.
Here, even though it was very Australian. So as I said, some of the legal advance directive things are slightly different, but at the beginning of the day I talked about when I first go and work with facilities, and I ask them whether they do palliative care case conferences, and they all tell me that they do, and then as we work through them, and they don't generally. So I'm not quite sure whether this is your reality, this is what happens, or not. So, yeah.
Did you think that he was a little wishy-washy around that starving to death answer?
Yeah, because
that's most contentious.
It is, because one of the things that we had to be mindful of is to keep the training resource down to less than 15 minutes. And so we don't unpack some of those difficult decisions in that. But what we actually suggest, and this is part of a whole pack, and we have a self-directed learning package attached to this. So you watch the video, and then you actually work through the self-directed learning package where we go through a lot of those things. So the idea behind this is it's a good conversation starter. So what would you have said? What are the main issues? So in many ways we left it in there knowing that we didn't address it properly as a prompt, and we thought that would be better. So
I would add to that in our toolkit we also have a brochure called Food for Thought. And Food for Thought, we adopted it from a group called NICE, the National Initiative of Care for the Elderly. And Food for Thought addresses directly why people reaching the end of life do not have an appetite, and why it's a natural part of your body preparing itself for the end of life. And we have used that brochure, and we have it in the homes, and the personal support workers and the nurses know where to access it, because it comes up in conversation. It's kind of an opening, a moment where you can then go and get that brochure and give it to the family, and they can take it home and they can read it. And families have responded very, very well to that brochure, because it's an ongoing conversation that happens in how many of you have had that conversation about the fact that the resident no longer is eating? Mm-hmm. Yeah.
One of the other things that I just point out is that we have the family, it's called the invitation to the case conference for the family. And that was what that lady the daughter was filling out. And that's taken from work done in Australia about family meetings. And we realised that for families to come to a palliative care case conference when they were unprepared was really unfair. And so the idea of actually them having something which explained what the case conference was going to be, what the time it was going to be on, where it was going to be, who was going to be there. But it also allowed them, there's a couple of questions in which talks about, we're doing that now?
Yeah.
Okay.
Right now.
So asking the family what do they want discussed at the case conference, and so they have to write that down on this form. They're also asked to rate how distressed or how concerned they are about those issues that they want raised on a scale of 0 to 10. So that we can gauge when they arrive at the case conference, the coordinator takes the form from the family member. Sometimes they give it to the RN before the case conference starts so that it can be looked at. But if not, it's done at the beginning of the case conference. And what that does is it immediately puts in the driving seat the family member rather than the GP or the registered nurse, because we really want to extract from the family or from the resident what are the main issues, because when we come to some of these case conferences, but and particularly with as a registered nurse, we're often thinking in that very medical focused way. But when we analysed what was coming out of those brochures and questionnaires that we'd given to family members, it was really more about the whole psychosocial needs, their needs, how do they get more involved with the residents' care, you know, what can I do to help? There was some focus on pain and symptom management, but I think that's partly because that's the language we talk about and that's what they hear. But there was also issues about quality of life, activities still, you know. Can they still do the activities? If they're deemed palliative, does that mean they don't get to go to the activities anymore? And of course the answer is no to that. But that was some of the concerns that the families wanted. I haven't got my glasses on.
Oh.
Yeah, I'm that old these days.
So we're going to think for a few minutes about Carolyn. Remember Carolyn, the resident that I introduced you to? And we're just going to think for a few minutes as a group. Like if you're the personal support worker and the registered nurse says we're going to have a palliative care conference about Carolyn, what are some of your thoughts about what information would be important for the personal support worker to give the nurse in advance of that type of care conference? What would you want to share? This is your very important information. What would you tell the nurse? Shout it out then. She's a risk for a fall, and would you give examples if you had some? Yeah. So because that was one of the things, a risk for falls for sure. Other things you would tell the nurse? Her preferences.
Like when it comes to bathing.
Okay.
And her what she wants when it comes to social, like she likes music, those kind of
Yeah. So
preference.
things that you know are very comforting to that resident from your experience, because that would help the nurse know more individual information about the resident.
And it should go also on the care plan.
Yes. What other things do PSWs know that you would really want to give input on? Yes? Language. Yeah. So in this case, Carolyn speaks English, but not every resident would speak English. So if there were particular challenges around communication or understanding. That's a very, very good point. And it's very, very common for people who have spoken English as a second language, as they, get more compromised or perhaps they have some more dementia, they will be more comfortable in communicating in the language that they're more familiar with. So those are some ideas of things that you would tell the nurse. What if you were? So that was actually in the video that Sarah, I think her name was.
The daughter.
No,
Natasha was the care worker. Yeah, in the blue
Now,
shirt.
Natasha was a carer, which means a personal support worker. So if you were the personal support worker sitting at that conference, How would you prepare for that conference? If you were invited to that care conference, what questions would you prepare and what would you want to know or communicate in that care conference from a personal support worker perspective? What information would you want to find out to care for Carolyn? Sorry? Medical history? Yeah. Yeah, but do you know that medical history, or what particularly would be important for you to know as a PSW? Yeah. Okay. Okay.
How about her hobbies?
Her hobbies? Yeah, so one idea was given, maybe you would share some of her recreational interests, but other interests about things that Carolyn might want to do, might want to enjoy. Other information that would be important to you as a personal support worker. Okay, you go ahead. I'm sorry.
What's happening to look for with arthritis,
Yeah.
all those things. She doesn't
Yeah.
how serious it could be.
Yeah.
Sorry.
Okay, so basically you gave many, many examples of, and I think it was similar to the point about medical history, but to get some guidance about what it is that you should be watching for, things that in the medical condition that would be very, very important. In your own homes, do you do a case conference similar to this, or what resources do you have if you do it a bit differently to have the conversations and get everybody, as they said, on the same page? Could you use the mic, please? The mic isn't on.
What we do when a new resident enters into a home, we have what you call a purple meeting, and that initially is where we gather the PSW, the activation staff, the nursing, dietary, physio, everyone, and we do initial assessment meeting with that resident and their family. And after about 3 months, we assess the go over the initial care plan to see what we can change and what has been changed. So that's some of the things. Then of course they ask the family, do they have an advanced planning, which you said is illegal, which I didn't know that's illegal. I learned something new today. And then they evaluate everything with that. And that's basically, I think, what we do. So that initial assessment, that first day, we get to know a bit more about the family. So then we have that and the residents, so we can go from there.
So that's your regular care conference that you would have, that very, very first one. Do you do anything special later on when the resident is changing? 3 months. So these are the regular care conferences that you would have. I just want to make sure that you understood what I said about advanced care planning and legality. It's not illegal to have an advanced care plan, or we would all be. But yes, you can't force people to do it, and it's not the same as legal consent to treatment. Yeah, it's not the same. So I just wanted to make sure that you understood what I said. Did you have a comment, Elaine, about other homes? Do you do something like a palliative care conference or a specific palliative care conference where you go into the kind of detail?
Only if sometimes the family requests.
Okay, so that comment was if the family requests it, you might do it, but it's not a routine part. You wanted to make a comment?
Yes, I just wanted to say that our home, long-term care home, even though the advanced directive may be a level 4, at the initial stage. And I noticed you were saying it may be illegal at that time, but it's generally a guideline as to what they want then. But that usually changes, and it has changed many times through the course of their stay and under which circumstances they may be under. But when it comes time for palliative care, there is a care conference where everyone is involved, and the families involved, where they would talk about what to expect and what guidelines to follow then, and what interventions need to be put in place. So that is certainly done at where I work anyway. And I know there is just going back to that video that was played, there is such a shift in language now that is being used, where I know the resident stated that he wanted to die at home rather than in an institution or in a facility. And now it is now the home is referred to as their homes, and we do not say that we are going to go to work. We are entering someone's home, and we see that. So they become that place is their home now, and it is treated as such. So they feel very comfortable. And we have had residents in the past that did transfer to the hospital and were in palliative care there at the hospital, and requested to return to their home to pass away rather than to pass at the hospital.
Thank you. Okay, so we're going to move on Carolyn's journey just a little bit, but I think I would make the point that from my experience, having some kind of specific opportunity in your home to talk about people's wishes, it's good to do it in the regular care conferences. I'm not suggesting it's not good, but often it's not enough. And you made an interesting point that the family might ask for it, but what families say to me is they want it to be offered to them, because it's really hard. You don't know what to ask for if you don't know that the care conference is available to you. So they want people, they look at you as the professionals, and if people seem distressed or there seems to be confusion amongst different family members, one family member comes in and says, my brother, you could say, why don't you ask for a care conference? Why don't you ask for a care conference? That's the advocacy role of the personal support worker that Marg and Jackie talked about so eloquently.
And can I just add, one of the other things is that, I'm not sure what happens here, but in most of the case conferences that we were involved in when we were doing this project, it was the first time that the family had ever met the general practitioner. So normally the resident gets admitted to the home, the GP comes in after hours, or not when the family's there, they write up the medications, they do the medical history, and that's it. They don't meet the family. So some of these people had been in the homes for years and had never met the general practitioner. And when we were setting up these case conferences, and we would say, well, of course, Dr. So-and-so will be there, but you already know them, and the family would go, nah, never met them, never seen them before in my life. And so that doesn't instill great confidence in the family that at the time when you most need it, that the GP is actually going to know what you want and what the resident wants. So that was a really fantastic experience to actually get the staff, the family and the GP in the same room and actually get, as I say, the name of the DVDs all on the same page. And that was an incredible event. So it's not only about nursing case conferences, it is as much as you can, try and get a doctor there as well, because there is decisions to be made.
In where I live in Thunder Bay, we have what's called a nurse-led outreach team of nurse practitioners, and we do have difficulty getting the physicians to come to, specialized palliative care case conferences, although one of them does, so that's wonderful and needs to be encouraged and nurtured. But the nurse practitioners have been excellent and can perform a lot of the same functions as you described, the doctors. So I'm going to move a little bit along because, my first bubble, the resident has come into the home. We need to understand what their wishes are, have a bit of a case conference, and then we need to really be able to get a better handle on when is this resident transitioning to benefit by a more palliative approach to care. And in fact, honestly, this should have come before the case conference because this kind of decision triggers and tells you when to have the case conference. So I'll just read you the last little bit of the scenario of Carolyn, and then I'm going to talk to you a little bit about this. So Carolyn's most frequent visitor, remember her son is a truck driver, he's on the road, he's away from home an awful lot, and Carolyn's most frequent visitor is Ivy. Ivy lived next door to Carolyn for 30 years and misses her greatly since she moved into the long-term care home. Ivy was very sad about Carolyn's move into the long-term care home and has been very supportive in Alex's absence. She calls once a day, every day, and visits as often as she can. So there's a family-like relationship, even though it's not a blood relationship. She adopted Carolyn's beloved dog, Levi, and Levi has offered Carolyn some peace about her transition into long-term care. Carolyn's condition appears to have declined in the last 6 months, and many of the personal support workers, including you, because remember Carolyn's in your home, suspected that she would benefit by palliative care. They notice that she's now mainly in bed or sitting in her room, and she's not interested in going to church, which she used to do regularly. She's changing. Things are changing. She now requires significant support with dressing. She's not eating as much, and she's more confused than she used to be on admission. One night, Carolyn cries out in the middle of the night, "Help me, I need to go home." What might Carolyn be feeling? Anxiety, fear, panic, pain? Is she seeing ghosts, delirium? You don't really know, do you? You don't really know what's going on when she cries out, "Help me." Carolyn states when you, the personal support worker, go into her room, she says, "Stanley woke me up and told me to come home." Do you remember who Stanley is? Yes, her husband. Has that ever happened to you? Anything like that? Oh, yeah. Upon responding to Carolyn's cry for help, she asked the following questions. This is the personal support worker. Carolyn asks the personal support worker the following question. This is Jackie's tough question. Do you think I'm going to die soon? Has anybody ever asked you that? Yes. How much longer do I have? I don't want to die alone. I wish my son was here. I need to see him one more time. Will there be a lot of pain? In asking you those questions, what do you think Carolyn is experiencing? What do you think? Fear, anxiety. Yeah. And she's looking for reassurance. So this is a very, very important time to be screening, and Deb talked about some of the screening tools. So some of this I'll go quickly. But remember I talked about the surprise question. Would you be surprised if this person died? And in this case, I think Deb's 6 months is more realistic. because this person is now transitioning when they're having that kind of anxiety and fear. And this is where the palliative performance scale that I made reference to can help you. You have that instinctive gut feeling that you know the situation's changing, you know that resident is approaching end of life, but you feel like you don't always have something tangible to back that comment up. So this palliative performance scale we have found to be very helpful to staff, and it's useful for managing change or understanding and observing change. So you remember I said, is the change year to year, month to month, week to week, or day to day? And this scale will help you with that. And it's functional, and it has 5 dimensions: ambulation, activity, the disease, the level of the disease, self-care, what can they do for themselves, what their oral intake is, and their consciousness. And then you give people a score from 0 to 100. So when someone is at 100%, hopefully that's all of us in this room, fully functioning in all of our domains. I saw you all eat lunch, so there was no problem with oral intake, except for the poor lady that didn't get a lunch, but that really wasn't her fault. But 0 is dead. And the way the scale works in 10% increments, you can describe the changes that you see. And it's not prognostication. It does not tell you how long the person has to live. It does not do that. What it does is it helps you demonstrate and communicate the changes that you see. So this is how it looks. So remember I said 100% is fully functioning, 0 is dead, and there's the domains across the top that I mentioned, basic things that PSWs see every day and families see every day. And then you can see the gradation. So we'll just take one for example, and actually this is the most important one, ambulation. It will tell you the most. So you'll see that ambulation moves from full, and remember the case conference from Deb, to reduced ambulation. Remember he was using a walker more. Remember Carolyn is at risk of falling. Her ambulation is reduced till eventually mostly sitting and lying, not getting up at all to move around, mainly in bed, then totally in bed, and that's till the end. So the yellow part is that transition to that palliative phase, where in here is when you see that resident transitioning. That's when you should start flagging, something is changing, we need to have a case conference, we need to make sure that we know the resident's wishes, because the red zone is when you're in that end of life, imminently dying phase. Now you don't know how long it's going to be, but you know that this is a sign of people who are imminently dying. The only exception would be, and there are some residents getting back to dementia who do deteriorate and somehow they stabilize here for a long, long time. And so if they stabilize, they're not changing, okay? So this is a scale about changing, and when you see the changes week by week, you know the trajectory that is happening. So all of our staff in the long-term care home were introduced and trained to use this scale, and it provided a common language, because instead of you trying to explain to the nurse all the details, You could say, you know what, when I left last week, Carolyn was at 40%. And now I've come back and you know what, she's at 30%. I think Carolyn is changing. And everybody knows what that means because you have a common understanding. I first was introduced to this scale when I was a PhD student. I spent some time working at Victoria Hospice, which is actually where this was invented, in Victoria, BC, on the hospice unit. And in a case conference at Victoria Hospice, when they had someone on home care out in the community, the home care nurse would call and say to the hospice team, Mr. Smith is at 30%. And they'd say, bring him in. That's all that had to be said, because everybody knew. It's like a code, a code language. But it allows you to describe. And you know what? That's so simple that families can understand that. And when families say, well, I don't know, things are changing, you could say, well, let's look at this and let's see what's been happening. Some of you earlier said you use the PPS. Hands up if you use the PPS in your home. A few of you. We have found that staff really, really appreciate it. And when we did a screen, we found actually like a lot of people who are admitted to long-term care are around this sort of 50 to 60% in here. And I mean, they may stay there for a long, long time, and then you start. Some people get admitted here, but often it's up here. And so that's how it works. And then you work, this is just another, I don't know why this stays here. It's different. Because that's Carolyn. Carolyn mainly sit or lie. Like if you were going to do Carolyn's PPS, she was mainly sitting or lying, and you would do a circle around it and then go to the next. And she's unable to do any work. She has extensive disease. And by work, in long-term care, work means your regular activities of daily living. What is it that the resident would normally do? Go to the dining room. In this case, she doesn't go to the dining room. And then you look, and she needs mainly assistance with her self-care. And she was becoming more confused. So you take the sheet, and it's best to do it as a team, not just you as an individual, but talk to your other PSW, the nurses, the PSWs, kind of have a little huddle and see if you can chart where she's at. And it's not always perfect right across like that, but that's okay. And usually the stuff on the left is more weighty, so to speak. You know how you collect RI data, in your home? So the biggest predictors of mortality are the functional ones, what people are able to do. So those are the heavy hitters. Another tool that we have is one to help with pain identification and screening. I don't have to spend much time because Deb talked about pain screening, and it's really all the same idea. But you should know that under the Long-Term Care Home Act, your home is required to have a pain management program. It doesn't say what tool you have to use because there's individual differences, but your home has to have a program and it has to have a tool. And I've been into long-term care homes who have said, oh gee, we don't have a pain management program. So either they don't have it or they don't know about it. How many of you are familiar with a pain management program in your home? And do you as a PSW participate? If you're a PSW, do you participate in screening? I hear yes and no, which doesn't surprise me either. So assessing pain is not within the scope of practice of personal support workers. However, identifying and screening for pain is your job, because you are the eyes and ears of the nurses. And if you don't go to them and tell them, you know, Carolyn, she's acting out, she's changing, she's either not doing things she used to do, or she is doing things that she never used to do. And so the PSW is really, really important in communicating issues and then monitoring if the nurse comes and gives a pain intervention, monitoring if it works. Because that's the second place where everything falls down, is there's not a follow-up assessment, you know, and it's not enough to just give it. You have to make sure it worked and communicate back. So this is what our tool looks like. And again, it's in our toolkit. And it's got the numerical scale that Deb talked about, you know, from 0 to 10. It also, for a resident who was unable, because you would ask the resident this, and to describe their own pain from 0 to 10, where you can ask. This is called the Modified Faces Scale, and you can look at that as an example of some of the grimacing. And then the CARE is the acronym for what your work is, and that is, and I'll just kind of quickly go through it. Your job is always, when you're observing that resident, and as Marg and Jackie talked about, that's what you're doing. You've got to always consider the presence of pain. You're always, always on the lookout for it. And then, A stands for, I can't even read. Assess. Screen. Yeah, so use your tools here. Use your tools. And then, geez, I can't. Reassess. Thank you. What does that say? Evaluate. Communicate. Okay, so it just walks you through your roles. So that tool, and it's a little plastic pocket card, you know, that you can carry with you. And we did lots of in-services with staff on that and train people. And again, it's not so much which tool you use. It's that you have a tool, you use it consistently, and everybody is on the same page. Oh, there it is. I didn't even have to. Okay? Okay. So we're just going to wrap up Carolyn in a few minutes. When you get closer to the end, we're looking at end-of-life communication. Just a minute here. And Jackie takes over.
Okay, I'm going to talk about the communication that I do in my home. So in my home, the staff-to-staff communication, when we have our residents at our end of life, we have a butterfly indicator. It is just a little butterfly that we can use to put on a resident's door after they have died. And this communicates to everybody, all staff, that this person has died in this room. We also have a palliative care bulletin board that we place outside of the staff room. And on this board, we put all sorts of things on it that are pertinent to palliative care, our palliative care team meetings, the people that are on it, things like that. Staff, resident, family communication, we have things that we've made up, comfort care bags. This is a bag that we give to the family as they are sitting bedside with their loved one. And in this bag are different things that we put in it to help them understand more of what is going on. I think I'm ahead of the game here. Sympathy cards, memory boxes, and placemats are some other things that we do with them. And I will explain that in a second. Communication issues. People using these terms, not always consistently. And it's really important that you do understand what these words mean and use them correctly. Different perceptions that people have. Palliative care is more work. Mary Lou talked about that this morning. Once you get on board with everybody and understanding the needs of your resident, it's easy. It's easier. So, like I said, the butterfly indicator, it is an accepted symbol. At least in Thunder Bay, we adopted it from our hospice unit. And like I said, it is a wonderful communication. We had just a quick little story. A resident died, and a housekeeper would go in every morning and clean the room and talk to her. And she did it that morning, and she couldn't understand. The resident didn't acknowledge anything, and she walked over, and here the resident had died. The housekeeper actually was telling me this story, and she said, I would never have gone into the room. I am not comfortable with that if I had known. We knew shift-to-shift report. We were just waiting for the funeral home to come, and so that was really sad for that housekeeper. If she had known, maybe one of us could have gone in with her, or she might have accepted it a little bit better. But we put these on the doors, and we also could use them on their charts to indicate that they are palliative. We also could use them on our board where we put our names on who's on the shift, and we have little butterflies that we can use to say that this person is on our palliative care team. And so if you had a question, you could go to this person. Like I said, the palliative care bulletin boards, we put our information on it. As we were going through our 5-year project, we had a tree, and the vision was you start at the roots and you work your way up. So us being the roots and learning and being educated and understanding what our role is, we built up the tree, and each leaf on the tree, and this was quite early in the project that this picture was taken, and on each leaf was a different initiative that we had thought up and put in place. So these are our comfort care bags. Like I said, they are given to a family member before the person has died, when the family is sitting there, and it's been really appreciated. I know I've given out many bags, and it's always a really wonderful feeling, not only for that family member, but for us to give back something to them. In it is, like I said, information. We always have pamphlets in it. We put in little different things like pads of paper and pens and candies. We've put in little toothbrushes or mouthwash. Sometimes they spend the night with them, and they really appreciate that. A lot of staff, it was all donated by staff. Some staff made things. We had one housekeeper actually dietary aide. She crocheted little not pot holders, but dishcloths, and we had those to put in there. We had a nurse that made little angels, and it was her therapy. She had lost a baby, and she made these little angels and called them Jesse's Angels, and she put a little sign on the back of each one of the angels stating who they were and why she made them. And it was really something that the families really, really loved to have. We had one family member that we give the bag to her, and she asked about the angel, and we always explained what was in the bag to them. And she was so thrilled with this angel and what it meant to that nurse for making them that she asked us when her mom died to please make sure Jesse's angel was in her hand. And it really was quite... I thought, oh, am I being cut off already? So it really meant something to her. Staff have designed sympathy cards. And it took us not too long. We found some beautiful poems and we decided that we were going to stick with the butterfly. It was all voted on. We made up our card. We're really, really proud of it. At a death of one of our residents, we get the card out, usually by the primary caregiver. Get a card, put it in the staff room. Everybody, all departments sign this card as much as possible. And it's really been something to be able to take these cards to our ward clerk, to have her mail them out after about a week's time. And sometimes I'll look at them, and it's really heart-wrenching to see some of the things people write in there. It's just shows how much our residents do mean to us, and they really are family-like to us. So it's really wonderful to be able to do that. Not everybody's able to go to a funeral, so this is our little way of having a little bit of closure. One of our community partners, Hospice Northwest, they have volunteers that make these boxes or decorate these boxes for us. We're very fortunate that they are in the same building as us, so I can run down and I can get these boxes. After a person has died and the body has left their bed, we take one of these boxes. It's like a file box, and it's got, like you can see, a beautiful poem on the top of it. It also has on the bottom a little blurb about counseling from them, that if they need it. And this box is used to put those special things of the resident in for the family. We had families coming in, and we were giving them garbage bags to put their stuff in. So this was just something really nice that we could do for them. Now, just quickly going back to Caroline, I just have a couple of little questions for you. Caroline's son Alex is at the bedside again, and Alex has not seen his mom in a couple of months. He is quite upset, and his mom doesn't have a lunch tray. What kind of place is this where you would starve people? Alex gets angry with his mom. You'd better start eating. This is enough foolishness. While Alex is visiting, he tries to force feed Caroline. I don't know about you, I've seen that. I've seen family members try to do that, and they push that spoon into their mouths. Anyway, Alex notices Caroline's glasses are broken, missing a lens, and complains to the PSW about the glasses. While Alex is visiting, Caroline begins to think that Alex is her husband, Stanley. While Alex is feeding Caroline, she begins to choke. Alex responds to his mom and becomes upset. "I'm not Dad, I'm your son." Alex leaves the room frustrated. So, recognizing that Alex is having a difficult time with the change in his mother's condition, how do you support Alex during this phase? What I would do, I would bring him the comfort care bag. In that comfort care bag would be the pamphlets on food for thought. You would also talk to him, make him understand that you feel his pain, that you understand that he has not been there for a while and how her condition has changed. They really want you to talk to them, not talk at them, but talk with them and help them to understand this change and help him to grieve for the loss that he is going to experience. Does anybody else have another idea of what you could do with that?
So that he,
I would hope that he was, but because he was out on the road, he probably wasn't able to get there quick enough.
No, I think sometimes families aren't notified soon enough.
Yeah.
And you leave them in a position when they come in, then they're angry at everybody, even the one that's dying.
Yes. Yes, you're right. You're right. In a lot of cases, that does happen. We know that we have a lot of times no family ever comes until the very end, and they do take it out on us. And we have to have those broad shoulders. We have to understand everybody grieves in their own way, and it's really important to try and put yourself in their shoes, right or wrong. It's their mom or dad that is dying, not ours, even though we feel they are ours. but we really have to be compassionate and try to understand. Another thing that I have to ask is thinking about the QPC tools that I just introduced to you, the communication tools that would support you at this time. Are there additional tools that you currently use or have access to that assist you in the situation? So what do you guys have in your home? Anything that I can add to mine?
In our home, we have a nurse that used to come to educate us how to take care of those under palliative care. So he has a very nice basket where you have a lot of things, the music and the paper, as you said, our family come around to stay. But the problem we are having, or I'm having, is that in our home, we have some rooms that are private room, we have semi-private, and we have the room that have 4 residents in it. If one of my residents is on getting palliative care, the other residents feel disturbed. How do I help them? This situation happened when I have a Muslim residence in a room and the other lady wasn't a Muslim. And the Muslim, they have the tradition, somebody is passing on the way they do, they come together, they eat, they are singing the song. So when I come, the other resident feel bad. She started crying. I've not been sleeping. These people are coming, eating food, and they are disturbing me. So I don't know what to do. I have to run in between repositioning my residence and giving a comfort care and also consoling the next one. But I have a perfect resident that passed on. That one was a Catholic. The man is a private room. We receive him from the hospital in a palliative care. So what they did is that he's alone in the room. The family come quietly. They stay there. They do their tradition until this man passed on. It was so lovely. We never take off anything in the room. They come and pick up the seat because they pay for private room. And I have another residence now. There are 4 in that room. Before you go in, you have to see the one receiving palliative care. The other residents feel disturbed, and the family also feel disturbed. People are coming in because we are not concentrating, we are not praying what is happening. So what is government going to do to help us, or the home, to provide a room for people receiving palliative care to be alone in the room? We do the job very well. So that's my question.
We can only do the best we can do, right? It's hard. It's really, really hard.
Sure, go ahead and
At our place where I work, we have a separate room when patients 2 and 3 and 4 in rooms, when they become palliative or sick, we take them down to the lounge and have the families and the patient there so they can be around by themselves, so nobody disturbed.
How wonderful is that?
Yeah.
In my home, I do have a palliative care room too, and it does really work well when you have where you have a louder family that are there. Or, yeah.
I really I've been in this field a long time, and the residents, as you probably know, did not used to stay at home to die in long-term care. It was common practice to transfer residents to hospital to die. I worked as a social worker in a hospital from 1972 to 1980, and nobody died in long-term care. So if you have an older home that has double and triple and 4 people in a room, it was built at the time when long-term care homes did not have a hospice-like function, So the reality of the care that we do is a mismatch with the buildings that we work in. And one of the homes in our project, which is the newest home, every room in the home is private. And that is the new standards for new build. So we're really struggling now, as you very, very well described, to kind of do the best we can. As Jackie said, there is a palliative room in Bethany, but I've been quite interested that in many cases, and probably you don't have more than 2 in a room, do you? 3. Many cases the resident doesn't want to move though, and the roommates actually don't want the resident to move because they have become like a community. So there's, again, like everything else, no one-size-fits-all solution. You're going to have to problem solve with the family, with the resident, and with the other roommates. So we're going to quickly do the last phase. I know, and I'll give you a break at 3 o'clock. So it's 10 minutes. And you and Jackie and Marg are going to, aren't you going to talk about the end-of-life input model, the bereavement?
We're going to forget the slides.
Yeah, forget the slides. So on your table, the very, very last page of that case study, and I know you don't all have it, but you can all access it on the website. You'll see that there's a description of this process that Marg and Jackie are going to talk about, which is called post-death debriefing. That's not the whole thing, is it?
We're going to do something different.
Oh, you aren't going to do that?
So are you.
Oh.
What's that?
We don't need a slide right now. Thank you, Ron. Just that's fine. We're just going to talk.
Save time.
Hello. Okay. We're winging it a bit here because the slides are like a crutch, you know. Now I have to go from my memory. Okay. When a resident dies, the team in Thunder Bay has developed a model, a debriefing model to help the PSWs who have been involved with the resident who has died. And there's an acronym that they use, and I think this is on one of the handouts that you've got, and you can go on the website that Mary Lou's been talking about all day, and you'll find lots of other materials to help you with this. There's an acronym that they've developed called the input model. So I-N-N, there's two N's, I-N-N-P-U-T. You know what? Why don't we act it out? Shall we? Okay, Mary Lou and I are going to be the two PSWs who have been involved with.
Us proud.
Shall we say Carolyn has died?
Yes,
Carolyn has died.
Okay, so that's what we're going to say, and Mary Lou and I have been the ones caring for her today, and Jackie is also a PSW who has been called from another place in our unit, knowing that our beloved Carolyn has just died. She is our peer debriefer. She has been appointed and been trained to be a peer debriefer to help other PSWs on the team who have just lost a resident. So Mary Lou and I are the PSWs at the bedside, and Jackie is coming to do a debriefing with us, actually on the floor, on our shift. And just half an hour ago, our resident has died. So Jackie's going to lead it.
So what I've done is I've gone around on the floor and I have gathered everybody that wanted to come. It's not mandatory that you go, but it's our way of letting go of this resident. So we're gathered into this room and I have two PSWs. So what I do is, the first thing I do is I introduce who it was. So it was Caroline, our beloved Caroline, that had come into our home so many years ago. She meant a lot to us, and we are going to do this debriefing right now just to make sure that you guys are okay. So you do the introduction. I have to ask if there's something that you need, something that I can do for you to help you get through this shift, through the day. Are you all right?
I just can't believe that she died now. I wasn't expecting it. I knew she was going to die, but I just didn't expect it to be today. I can't quite. I can't. I didn't even say goodbye.
It's hard.
So you're so shocked. I was so shocked too, and her son was so upset and so and crying, and my heart just went out to him, and I just feel exhausted, Jackie. I just feel exhausted.
I can see that in your faces. I didn't know Caroline really well. Tell me a little bit about her. Why was she so special to you?
Well, she was warm and funny, and she would speaking English, and then she'd start to speak French. She'd forget to speak English, and then I'd comment on it, and she'd laugh, and we'd tease each other, and she just was, and she didn't get a lot of company. So we spent a lot of time, chatting.
I saw you guys go into the room often.
Yeah.
And I remember the day that just last week I was caring for her, and she was crying, and she asked me to climb into bed with her. She thought I was her sister, and I didn't know what to do. I didn't know what to do for her.
It's hard. It's really hard, but I'm sure at that time that probably meant the world to her. And I know that from the stories that I've heard around the floor that you guys all meant so much to her, and that was really important. So a plan would be the next part in this. What are we going to do? Do you have any, I would really like one of you to write her name on our leaf, and we're going to put it on our tree.
I'll do that.
On our memory tree. And it's amazing how many times over the next months that we will go to that tree and look at that leaf and remember Caroline. And it's very, very important to us.
I'll do that.
Wonderful.
And I just really feel like I have to speak to her son one last time. I mean, he left upset. I was upset. It doesn't feel finished for me.
No, it doesn't, yeah.
So I'm gonna send him a card and invite him to call me if he wants to talk to me.
That's wonderful. That's wonderful.
And I'd like to go in the room one last time. I haven't.
Of course, yeah. Of course. Let me know when you're finished, because I do have a couple of residents that want to also go in before they come and take her. And they need to say their goodbye also. So I just want to say thank you to you two for all the work that you've done with Caroline. On the floor, I wasn't able to get down on that end because I work on the other end, and I understand what she meant to you. And I just want you to know that I'm there for you if there's anything that you need. And thank you for everything that you've done for Caroline.
So what we're trying to show you just really quickly is that there is a role for a trained peer debriefer. We all believe, we've been using this in Thunder Bay to great success. It's quick. It provides support to the people who are the most important in Caroline's life at the end, who may need a few moments to talk about her, to say last things, to say what they need to do to take care of themselves in order to continue on working that shift. And one of the things that Jackie will do as a peer debriefer is she'll probably check in with me later in the week to make sure that I'm doing okay. She'll be watching over me. So this is something we highly recommend, and you can go on the website and have a look. There's a whole workshop there that you could do to guide your own home through a training process to develop peer debriefers. We highly recommend it.
And when we do it, sometimes, like this only took a few minutes, but just to give you a rough idea, sometimes it takes us a half an hour. It depends on the group in there and what they need to say. And it's, like I said, sometimes it only takes 5-10 minutes, and then sometimes it is a lot longer. But the important thing is for them to get that out.
There's a question here.
I was just going to say about involving all the team members. So you're gathering the people in the unit, but maybe the housekeepers, you know, in the basement, or someone's downstairs in the kitchen.
Yes, absolutely. Yes.
Yeah. So my point was just to make sure that you're inviting all team members. So you might be walking through your floor and saying, oh, we're going to gather around the nurse's station or whatnot, but not to forget that your housekeeper might be down in the basement, or someone might be, you know, down in the kitchen, and to invite them to join as well.
Yeah, yeah. Thank you for that point. Yes.
Can you just tell me then, Jackie? Just tell me, Jackie, then, with your example of yourself, when you walked out and were accosted by several other residents, was something missed there? How soon after a resident dies is the debrief happening, and who missed you in that scenario?
We're in the midst of training, okay? I still have to get it through to my coworkers. We do have to watch each other. That example was, it had just happened. And those residents are constantly after me. They're mine, and they're constantly on me. We usually will, when a resident dies, depending on when they do, we pick a time in the day where it's a little quieter for us. And so usually it's at 10:30 in the morning or at 2 o'clock in the afternoon. We pick those specific times, 7 o'clock in the evening. And so we do have a little bit of time most of the time to go around the floor, making sure that everybody is aware that we're going to be doing this. And it is really important, you know, just to get it out there, to make sure people know that we are going to do this. Sometimes that's all they need. I've also had coworkers that say, no, I'm not going. I don't talk about death. I don't, after somebody's died, I do not talk about them. And that's okay. That's okay. That's their belief. That's their custom. I did notice, though, that down the road, she was coming. And she was talking about it also. So it's, you just have to be there for them. And like we were saying, you really have to watch your coworkers, because sometimes they really hurt. They really hurt. And by watching them and seeing that they're a little bit more quieter than usual, just be there for them. Sometimes it's you can do a small thing that can really change a person, and just to make them feel valued, and that's what we're there for. We're there for the resident, and we are there for each other, and we don't come into this job without these big hearts, right? And so make sure that heart is there for your coworker also.
Okay, so we're going to take your break till 3:15. And then we've got only one module left, which is how to go back and bring this information back to your home and try and light a fire under them to develop a formalized palliative care program. Yeah.
Are there any? No.
No.